So I want to welcome you to a very important class today, a high yield review class. Again, we are dealing with the concepts which have been revealed by the Medical Council itself, okay, so that candidates can get the best out of their exam preparation. And that is what we are dealing with today. So I'm going to dive right in today. Today, the class is going to focus on postpartum hemorrhage. And so let's get into it right away. Again, the Medical Council has some free lessons for you. I need you to go out there, review those free lessons for your exam preparation, because it helps you to know how the examiners are thinking and how best for you to position yourself for this particular exam. And so this is the question which they let out. And it says that you have an 18-year-old woman who is in hospital and has delivered her first child who weighs 2,500 grams following a short second stage delivery. Now, the patient has a history of heavy menstrual bleeding. 2 hours after delivery, she has profuse vaginal bleeding and hypotension. Her fundus is firm and 6 centimeters below the umbilicus. Which one of the following is the most likely cause of the increased bleeding in this patient? A, uterine atony. B, coagulopathy. C, cervical laceration. D, uterine rupture. And E, endometriosis. Make sure you also send the YouTube link to as many friends as possible to get them to join. So the question is, what is the correct answer from your perspective? Is it A, is it B, is it C, or is it D or E? Don't forget to send the message of MedCognito to as many friends as possible. So what I'm seeing here is that I see a lot of doctors who are going for B, B, B. And the correct answer is B. Yes. Now, what are the clues in the question stem which points you to B? Before that, let's look at the rationale that the Medical Council gave. And then we will use that to delve deep into the concept of postpartum hemorrhage, which is a very important MCCQE1 concept, right? So it says that this patient's history of heavy menstrual bleeding suggests an underlying bleeding disorder. Now, look at this very well. This patient is 18 years old, and this is her first child. So it's not like she's a grand multip, and for which reason her uterus has gone through so many deliveries and she's at risk of postpartum hemorrhage. Look at the weight of the baby, just 2,500 grams. So the baby is not too big. And we know that one of the causes of postpartum bleeding is a big baby, right? And then the examiner also gave you this clue that it was a short second stage delivery. In other words, it's not a long, protracted second stage, which can cause a lot of trouble. But then that one clue of the patient has a history of heavy menstrual bleeding is what gives it away that this is a coagulopathy. That is it. And I'm going to take time to, delve deep into these things. So the patient's history of heavy menstrual bleeding suggests an underlying bleeding disorder. This patient had this even before the patient got pregnant. So it looks like the ground was set for postpartum bleeding even before the patient got pregnant, pointing towards coagulopathy as the most likely cause of the increased bleeding. Now, coagulopathy can lead to excessive bleeding due to the inability of the blood to clot properly. And that was what the patient was having before she got pregnant, which aligns with the patient's symptoms of profuse bleeding and hypotension despite a firm uterine finding or fundus, sorry. And this is also something I'll be talking about as the class goes on. How do you use a stepwise approach to tell what the actual diagnosis is, and how do you even use an actual approach to tell how to manage a patient in postpartum hemorrhage cases? Now, it says that uterine atony can be ruled out as the cause of bleeding Why? Because since uterine atony would typically result in a soft and boggy uterus. So in your board exam, that's something you want to watch out for. What are the features which point to uterine atony? I'm looking for a soft and boggy, like, it's very big and boggy, right? Boggy uterus after delivery. Number 2, uterine rupture is also unlikely because it was one of the options, because the uterus is firm and there is absence of severe abdominal pain or signs of shock. So that's another clue there. If you want to pick up a case of uterine rupture in your board exam, please look out for clues which the examiner will say just after delivery, the patient has a very tender abdomen. And then maybe look at the vital signs of the patient. You realize that the patient is obviously in shock, right? And then another option was endometriosis. And you realize that endometriosis is an infection of the uterine lining. And usually endometriosis will not present just there and then. It will not present acutely in a patient who has just delivered. And then one of the options was also cervical laceration. You realize that with cervical laceration, the uterus will be firm, but then you may be told that, this was a difficult delivery, and so they had to do some instrumental things, like maybe using a forceps, and it will give you okay, maybe that is what caused the laceration. Okay, so these are the things I want you to pay attention to in your board exam, because the MCCQE1 exam is basically an exam where clues are being left, and it is up to you to go in there to review it. Now, again, I'll say this again and then again and again and again. The Medical Council of Canada have already told you where you should be studying from. And so they give you 2 references, and I took a picture of those 2 references for you. Okay, the first reference was where they got a question from, and then the second reference is a textbook. So this is where they got this particular question from. Okay, and that is why for me, I'm going to be an ambassador of please use the right materials. Again, Toronto Notes is a very, 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 very good book. However, the way certain concepts are put, you really need to have done broader reading beyond Toronto Notes to be able to get the concepts right. So this is the first reference which they use, which is the National Library of Medicine, and they got this from the postpartum hemorrhage section. And then there's this other book which they made reference to, which is Current Diagnosis and Treatment, Obstetrics and Gynecology. Now, somebody may say, Dr. Boni, you've been talking about this all this while. How do I search for the materials the MCC wants me to use directly for myself? How do I do that? Let me take you to Google, and then I'll show you how to do it. Okay, so I'm going to stop sharing my screen for now. I'm going to, let's do it together. Let's share the screen. Okay, good. No, let me go to google.com. Okay, now let's share my screen. It says your browser has blocked your screen. Click the screen icon in your address bar to allow screen icon. Let's see, what does that? Oh, I don't know what is going on here. Your browser has blocked your screen. Click the screen icon in your address bar. Where is that? Where is the screen icon? I don't know how to do this. Well, I don't know, because I wanted to share, like, there's a whole MCC place where you can type in even what you are learning, and it will direct you to specific things. Click the screen icon. Screen icon. I'm looking for screen icon. Okay, all right, sure. Let me, please, can you see my new screen? I just want to know. Can you see the new screen I'm sharing? I just want to know. Okay, good. Now, let's do this. So let me say, let's go to google.com, okay? Google.com. Now, if you go to google.com and you want to do this on your own, doctors, please, do you see the screen I'm sharing? Okay, good. So you go to google.com and you want to see the thing I'm sharing. Let's go to MCCQE1. MCCQE1 reference materials. Okay, let me just say that. Okay, good. So you see that the medical council has given you, please, doctors, I want to make sure, are you following me? Can you see my screen? Can you see my screen? Okay, good. Now, because I want to let you know why they made reference to that book. Now, if they go resources to help you with your exam preparation. Okay. Now, when you go here, you see that they have free resources, explore free resources. Now, when you go to explore free resources, you see all these things, okay? And then it will bring you to this page. You scroll down, it will bring you to this page. Now, all you need to do is, I'm preparing for the MCQ1 part 1. I'm on the MCC website. I'm sure many of you have not even seen this before. So that's what I'm drawing attention to. MCQ1 part 1. I'm interested in resources on let's say, let's not even go. Okay, I'm preparing for the MCQ1, but I'm interested in resources that are books. Okay, so just say textbook. Why am I referencing that book? Now you realize that every day I talk about specific books that you need to use. This is what the MCC wants you to use. So the Hospital for Sick Children Handbook for Pediatrics, Kaplan for Psychiatry, right? But then you remember that I was talking to you about Tintinali, this book. Where is my copy? Let me get my copy. I'll look for my copy and then show it to you, okay? And then this is the SHAS Public Health. But where is the obstetrics and gynecology book? Obstetrics and gynecology book, each 2. You realize that that book I was making reference to, this book, this is it. This is the book I was talking about. So you realize that in their free questions, they make reference to that book, and on their website as well. If you go and you say you are looking for all the textbooks you need for the MCQ1 preparation, and you type that in, it will bring you to this particular website. And this particular website contains all the books you need. In fact, if there are podcasts you want to listen to, all you need to do is to change your search bar and say, I want the resource, I'm interested in resources that are podcasts. You click that, it will take you to resources that are podcasts that you need for your MCQ1. Doctors, look, the whole point is you need to know what you need for the exam. The MCC has done so much for you. For example, I want material which focuses on videos. The MCC has already generated some video, or they've put in some video links. Doctors, please, is this helpful? I just want to know, is this helpful before we even finish it? Is this helpful? Is this helpful? Because a lot of people just come in, everyone says Toronto Notes. I'll say Toronto Notes is an awesome book. Use it. However, don't forget to also use approved materials. Don't forget to use approved materials, my people. I beg you. So you realize that in MedCognito, I don't just talk about Toronto Notes. No, Toronto Notes, use it for your reference. But if you want to do deep dive into medical ethics, go for doing it right. If you want to do deep dive into obstetrics, use this particular book. If you want to do deep dive into pediatrics, the Medical Council of Canada has a book. If you want to do deep dive into emergency medicine, use Tintinali. I plead with you, Please, I will keep hammering this over and over and over again. So if you want a copy of, if you want a link to that website, I'll just copy it and put it in the comment section so that you know that this is what the medical council is actually referencing. I'm putting it in the comment section right now. I've put it in the comment section, so you should see it either on your Facebook feed or on your YouTube feed. Okay, I've put a link, the direct link, which will take you to that particular place, which contains like the videos, the textbooks, all those things you need. I've put it in the comment section. Please, if you received the link, just type yes before we continue, because today's class we have so much to cover. But for me, I was like, you know what? I really want you to know and understand why the MCC chooses like to set questions from specific textbooks. It is because it is on their website, but it's all about how to browse and get to that particular point. Okay, so now that I'm done, let me remove this and then let's go back to it. So when it comes to obstetrics and gynecology, this book should be your number one book. This book should be your number one book. Current Diagnosis and Treatments of Obstetrics and Gynecology. This is where, and then what you do is, I will pick the objectives and then go into, you don't need to read this whole textbook, no, but pick the objectives and then look at the objectives which fall under obstetrics and gynecology. Then go there and review those things in that particular book. That's all. Doctors, please, can I proceed with the class? Can I proceed with the class? I want to know, because today I really want to take my time and make sure that you really get everything. And someone may say, okay, Dr. Boni, what are the topics I need to cover in obstetrics and gynecology? I'm going to tell you right now, so that when you pick this book and you open it, you know exactly the topics to cover. Let me go to obstetrics and gynecology. I've already done that for the MedCognito students, and you guys also know it. But if you want a copy of the objective book, please. So if you want to master the topics you need to master for obstetrics and gynecology according to the MCC objectives, I have it here. Number one, you have to master hypertensive disorders of pregnancy. Please write it down. Number two, you have to master early pregnancy loss and spontaneous abortion. You need to master that. Number three, you need to master intrapartum and postpartum care. And that is why, even in their free questions, they just dropped a case on postpartum hemorrhage. Doctors, everything is connected. Everything is connected. Okay, let's continue. Another topic you need to cover in obstetrics is prenatal care. Another topic you need to cover in obstetrics is preterm labor. And the last topic you need to cover in obstetrics is intrauterine growth restriction. These are the 1, 2, 3, 4, 5, 6 topics you need to cover in obstetrics. If you're able to cover those topics, you are good to go. If you're able to cover those topics, you are good to go. These are the only topics you need to cover in obstetrics, so far as the MCCQE1 website, the MCCQE1 objectives are concerned. Now, the last time I did the counting, there are about 198 objectives. And when it comes to obstetrics, these are the things: hypertensive disorders of pregnancy, early pregnancy loss and spontaneous abortion, intrapartum and postpartum care, prenatal care, preterm labor, and intrauterine growth restriction. Now, doctors, if you want a copy of this simple thing, just send a message to me at +1 306 891 5649. I'll send it to you. It's free. We looked at all the objectives and then we grouped them for you, so that now, if you go into this textbook, you're not reading the entire textbook. You are just focusing on these six areas. And of course, these 6 areas may have sub areas as well, right? Please. So my point is this: number one, use the MCC objectives. Number two, use the approved books and materials and do reverse engineering. Go back, review only those topics in them. Even if you want to use Toronto notes, don't waste your time reading everything in Toronto notes. Rather, if it comes to obstetrics, go to the MCC objectives. Okay, what are the objectives wanting me to know? And then focus on those topics and you're good to go. The last time as I counted, there are only 198 objectives. The CCFP exam has 105 objectives. The emergency medicine exam has only 35 objectives. Okay? In the TDM exam, they follow the same pattern for the CCFP. So the TDM, you need to cover like 105 objectives. Doctors, this is what we focus on at MedCognito. Every day, there's not a single day we are not doing something about MCQ1 for you. And that is why I have all this information to share with you. Okay, so let's go back. Please, I have a question. Is that clear? Do you have any question before we even move on? We left the class and I was like, no, what? Let's talk about resources. So is there anything you want to ask? If you have any question, just ask the question right now. Then I can talk about that before we go into the class again, because look, there's so much you need to have for this exam. And that is why, you know, when people are looking for shortcuts and errors, I go like, no, at MedCognito, we will give you the real deal. We will, it's a lot of topics you need to cover. You need to cover everything. If you want high yield topics are the 198 objectives. Make sure you've covered everything. Can we move on? Okay, good. Let's go. Let's go. Okay, so how did I get here? Because it's on the MCC, it's on the MCC website. And when they set this particular question on postpartum hemorrhage, this was the reference material they used. Okay, good. So I need you to always think about the way the examiner always thinks. Okay, that's how you need to think. Now, if you look at the question, the examiner is trying to see, can you recognize postpartum hemorrhage as an exam taker? Number two, can you use the uterine tone to narrow the differential diagnosis of postpartum hemorrhage? So if we say that the uterus is boggy and enlarged, what's your diagnosis? If we say that the uterus is firm and the patient is still bleeding, what are the diagnoses which will come into your mind? Okay, and then can you integrate the patient's history in determining the cause of postpartum hemorrhage? And how do you avoid bad answers when the examiner is giving you an obvious clue? Because in this particular question, the obvious clue was the baby is not large. This is a first-time delivery. It wasn't a prolonged second stage. But then before the patient got pregnant, the patient already had a bleeding disorder. But they didn't say that the patient had a bleeding disorder. They just said the patient has a history of prolonged bleeding. That was the subtle thing they put there. And that is why they said, what could be the cause? And they said the answer is coagulopathy. So doctors, please remember, MCQ1 is not a memorization exam. It is an exam of pattern recognition, and it's a very practical exam. So my question is this: whatever training you are taking, whatever academy you are attending, whatever book you are reading, can you recognize patterns of postpartum bleeding when you're under pressure? And can you use physical exam to narrow the differentials of postpartum bleeding? So concepts that you need to review under this postpartum bleeding objective is, what are the management steps in postpartum hemorrhage? What is your initial stabilization plan? What laboratory investigations are you going to request for coagulopathy? How will you manage von Willebrand disease in pregnancy? When are you going to suspect cervical laceration as a differential diagnosis in a patient who has postpartum hemorrhage? What about massive transfusion protocols? Do you know about it? Right? What about secondary postpartum hemorrhage? And what are the risk factors for uterine atony? If you've not reviewed all these things, doctors, you have not reviewed postpartum hemorrhage. You've not done that. So let's do a deeper dive into the concept of postpartum bleeding. Now you have to understand the 4 T's. I call them the 4 T's. The 4 T's of postpartum bleeding. Number 1 is uterine atony. That's what you talk about, a boggy, enlarged uterus, right? Number 2 is uterine or cervical or vaginal laceration and trauma and uterine rupture. Number 3 is tissue, where the patient can have postpartum hemorrhage as a result of retained placenta. And the 4th point is thrombin, and that is what this 18-year-old girl in our question stem had, which will lead to coagulopathy. So doctors, I'll pause here, please. I need you to take notes of this. What are the 4 T's of postpartum bleeding? Number 1, tone, that is uterine atony. Number 2, trauma, that is lacerations and rupture of the uterus. Number 3, tissue, that is retained products of conception. And number 4 is thrombin, That is coagulopathy. Okay, coagulopathy. So let's develop a step-by-step thinking pattern for this thing. Number one, you need to recognize postpartum bleeding is an emergency. And that is why I always say that, in the MCC exam, you are being tested on, are you a safe doctor? Like, can you identify a patient who is about to die or a patient who is about to lose a limb? We call it life and limb issues. And then number two, are you able to act quickly? Know what you have to do first. So what are the things which point you to postpartum hemorrhage? A patient who has just delivered and a patient who has profuse vaginal bleeding. This patient's blood pressure is hypotensive, or the patient is hypotensive, and this is happening within 2 hours of postpartum hemorrhage. This is what we call early postpartum hemorrhage. There's also another type of postpartum hemorrhage, which we call late postpartum hemorrhage, but I won't go into that for today. Number two, when you're assessing a patient with postpartum hemorrhage, you want to assess the tone of the uterus. So in your question stem, ask yourself, what is the examiner saying about the tone of the uterus after delivery? Is the uterus firm, or is the uterus buggy uterus? If the uterus is stated to be firm in your board exam, then you have to understand that you are not dealing with a case of uterine atony. Then it could be a coagulopathy, or it could be a trauma. Because you can still have a normal, like a firm uterus, but if there's cervical laceration, the patient will still have postpartum bleeding. Or you can have a firm uterus just after delivery, and yet the patient has postpartum hemorrhage. Why? Because the patient may have a coagulopathy. So identify postpartum hemorrhage. Number two, as soon as you identify it, assess the uterine tone. Is the uterus firm or boggy? If the uterus is firm, then it is not uterine atony. Number three, you've got to then integrate the history, right? Before the patient even got pregnant, did the patient have heavy menstrual bleeding? If you see that, like what we saw in this question, heavy menstrual bleeding even before pregnancy and delivery will suggest that there could be a bleeding disorder like von Willebrand disease, like platelet dysfunction, like a coagulation abnormality. Doctors, I want to pause here and I want to make sure, please, are you tracking with me? Are you tracking with me? If you are tracking with me, say I'm tracking. Type tracking, Dr. Bonnie. We are tracking together. We have a long day today, but I want to make sure that we are building the foundations step by step. Are you tracking with me? If yes, type yes, or type tracking. I want to see the word tracking in your comment section. Tracking. We are tracking together, because we need to get these concepts right so that nobody can bully us in the board exam. We don't want anyone to bully us in the board exam. We want to get it right. Okay, tracking. Beautiful. Now let's go back. Okay, so doctors, please, we are moving step by step. So if there's a case of uterine atony, how will I pick it in my board exam? It will present with a soft, boggy, enlarged uterus. These are the three clues you have to look out for. The uterus will be described as soft. The uterus will be described as boggy. The uterus will be described as enlarged. What about cervical laceration? What are the things which should point you to cervical laceration as a differential for postpartum hemorrhage? Always remember, one trick is that if you are told that the uterus after delivery is firm, has become firm, maybe you gave oxytocin and the rest, and the uterus has become firm, but then the patient is still bleeding, then ask yourself, go back to the question stem and ask yourself, was there any use of instrumental delivery, like forceps delivery? Was there any prolonged second stage? Was this a difficult delivery? Was there trauma during the delivery? If you start seeing those kinds of clues, it tells you, hey, this is cervical laceration. If you start seeing those clues, instrumental delivery, prolonged second stage, difficult delivery, trauma during the delivery, start thinking about cervical laceration as a result of the postpartum hemorrhage. And most of the time, in that case, you'll also be told in your question stem that the uterus is firm. Then how do you pick up uterine rupture? As a differential of postpartum hemorrhage. Remember, when we're talking about obstetrics high-yield topics, postpartum care is one of the top things you need to know. So uterine rupture, how do you pick that up? You realize that a patient with uterine rupture will present with severe abdominal pain. You'll be told in your question stem. The patient will have hemodynamic collapse, so the pulse will be very high and the blood pressure will be low, and the patient will have maybe increased work of breathing. Sometimes you may be told that, the patient's oxygen saturation is dropping precipitously. And you realize that the patient may present a very dramatic presentation. In fact, you may even be told that when you try to do an abdominal exam prior to delivery, you could feel fetal parts. When you see that you can feel fetal parts in the patient with severe abdominal pain, in shock, and after that the patient delivered or whatever, or you did your cesarean section, whatever, and the patient is bleeding, think about uterine rupture. What about endometriosis? As I said, usually you realize that endometriosis will not present acutely. Usually, it will not present acutely. The patient will be presented as a patient with fever, uterine tenderness, ouch, when you're trying to do an abdominal exam, so much pain. But this may happen days after delivery, right? They may have foul vaginal discharge. So the lochia, which is coming, will be foul smelling. And you realize that the uterus is, and this happens later postpartum. This does not happen like the acute bleed we are talking about all the time. So let's deal with some further questions. Doctors, did you pick up what I just laid down right away? Did you pick up what I just laid down? If you did, let me know. Did you pick up what I just laid down? Like the foundations, before we move on to, the question I want us to deal with. Today, we will just make sure that we master this concept very, very well. Did you pick up what I just laid down? Because we're going to try some questions and then we move on to the next point. Okay? Good. Let's go. We are leaving no one behind. Let's go. So, I have this question for you. A 32-year-old woman delivers a 4,200 gram infant vaginally after prolonged labor requiring oxytocin augmentation. 30 minutes postpartum, she develops heavy vaginal bleeding and hypotension. On examination, the uterus is soft, enlarged, and poorly contracted. Which of the following is the most likely cause of her bleeding? A, cervical laceration. B, retained placental tissue. C, uterine atony. D, coagulation deficiency. And E, endometriosis. Doctors, please don't forget to hit on the like and subscribe button on our YouTube channel right away. Share the link with as many friends as possible. Get as many friends as possible who are preparing for the MCCQE1 to come and feast on everything in MedCognito. You go to our live section, everything is there for you. Okay? So get your friends. What's the correct answer? Is it A, cervical laceration? B, retained placenta tissue? C, uterine atony? D, coagulation deficiency? Or E, endometriosis? And I see a lot of doctors going for C. And C is the correct answer. Uterine atony. Why uterine atony? Because the uterus is soft and large, poorly contracted, right? And that immediately points to uterine atony. And what are the risk factors for uterine atony? Number one, prolonged labor. This patient had it. Number two, oxytocin augmentation. Number three, macrosomic baby. These are the concepts, right? Why were the other options wrong? Cervical laceration was an option. Cervical laceration, as I said, will present with a firm uterus, but the patient will still have continued bleeding, not a soft, boggy uterus. What about retained products of conception? It may cause bleeding, but the uterus is often not there, not too atonic, right? A very, very soft, boggy uterus in this question points more to uterine atony than any other thing. What about coagulation issues? In coagulation issues, we learned that the uterus will be firm and there will be diffuse oozing, and the patient may be bleeding from multiple sides. So if it's a very bad coagulation concern like disseminated intravascular coagulation or something, you may even realize that the patient will be bleeding from the IV line sites, right? Yeah. And then what about endometriosis? We learned that endometriosis would present later, not right after delivery. And there may be fever, there may be uterine tenderness, and not an acute hemorrhage 30 minutes postpartum. So the teaching point is very simple. If there's a soft uterus, think about a tone problem, uterine tone problem. Uterine atony is the most common cause of postpartum hemorrhage. Okay, let's try another question. I have a 29-year-old woman who undergoes an instrument-assisted vaginal delivery. That is very simple. 2 hours later, she develops significant vaginal bleeding and hypotension. On examination, the uterine fundus is firm and well contracted. Inspection reveals continued bright red bleeding despite uterine massage. Which of the following is the most likely cause? A, uterine atony. B, cervical laceration. C, retained placenta. D, subinvolution of placental site. And E, HELP syndrome. This one is easy. That's it. Easy, that's it. Easy. And what's the correct answer? It's cervical laceration. Cervical laceration. Why? What points to cervical laceration? Because of that history of instrumentation. Right? So, first, we're able to identify that this is a postpartum hemorrhage where there's significant bleeding and hypotension. And then we assess the uterine tone. The fundus was firm, right? And so that rules out uterine atony. And then we looked for the risk factors for trauma. This patient had instrument-assisted vaginal delivery. And there was bright red bleeding with a firm uterus. So think about trauma. All right? I think we've already gone through why the rest of the answers would be wrong. Uterine atony, soft boggy uterus, retained placenta more commonly will present with failed placenta delivery, or even if the placenta was delivered, there may be some portions of the placenta which will not come out. And then subinvolution of the placenta site, it will typically cause secondary postpartum hemorrhage, which will happen usually days to weeks later. And for HELP syndrome, the patient will have coagulopathy. It will be oozing and they may be bleeding from multiple sites, not just the uterus alone. Let's try another question. You have a 34-year-old woman who develops heavy vaginal bleeding 20 minutes after vaginal delivery. She's hypotensive and tachycardic. While uterine massage and oxytocin are initiated, laboratory studies are sent as part of the postpartum hemorrhage protocol. Which of the following is the most appropriate next step while awaiting laboratory results? So we are entering into the realms of management. Right? A, delay transfusion until hemoglobin levels are available. B, begin aggressive resuscitation based on clinical assessment. C, wait for coagulation studies before administering blood products. D, repeat complete blood counts every 6 hours before intervening. And E, defer intervention until fibrinogen results are reported. Is it A, is it B, is it C, is it D, or is it E? What's the correct answer? So I see a lot of us went for B, which says begin aggressive resuscitation based on clinical assessment. And that is how, so you see the MCCQE1 is not expecting you to have all the information before you make a clinical judgment. This is another skill you need to master. You don't need all the information before you make a clinical judgment. The answer will be B. Begin aggressive resuscitation based on a clinical assessment. So what you have to understand from this particular question stem is you've got to understand lab timing. Okay, the question stem we just dealt with, it's dealing with so many things. Number one, laboratory values will lag behind clinical picture. So you have somebody who has postpartum hemorrhage. At times, you take the blood sample there and then. You take it to the lab. The hemoglobin might not have dropped precipitously, even though the patient is bleeding profusely. So what you have to understand is that in postpartum hemorrhage, the laboratory values can lag behind the clinical picture. In acute postpartum hemorrhage, it is the clinical instability of the patient which will determine the management. And so you don't want to say, I'm waiting for labs, I'm waiting for labs, I'm waiting for labs, I'm waiting for labs. No, or else the patient will also say, I'm waiting for you at the morgue. If you keep on saying in the case of postpartum hemorrhage, I'm waiting for labs, I'm waiting for labs, I'm waiting for labs. No, the patient will say, I will wait for you at the mortuary. And that would be a big thing. So if there is a case of postpartum hemorrhage, don't wait for all the labs and everything before you start intervention. After all, what does it take to set an IV line? After all, what does it take to request, 4 units of O negative blood? I'm not saying you're going to give it, but you're requesting it. What stops you from giving some IV fluids? What stops you from giving some oxytocin, right? What even stops you from going further to do some uterine massage, right? So you need to apply the protocol logic. Resuscitation must begin as soon as delivery happens. Vital signs, if there is ongoing bleeding, if the clinical appearance of the patient is changing, start your resuscitation. Don't wait. Don't wait at all. So why were the other answers wrong? Delaying transfusion until hemoglobin levels are available. Hemoglobin may not drop immediately. That was what I was explaining. And waiting could worsen the shock the patient is in. What about waiting for coagulation studies? If the bleeding is severe, you should start the treatment even before the labs return. What about repeating complete blood count before intervention? That's also wrong. Monitoring the complete blood count is important, but not before stabilization of the patient. Stabilize the patient. Come on. Give the fluids. Give do the uterine massage. Look for the source of the bleed. You can even do, you can even put a tamponade in, and we will discuss all those things. Don't wait. Don't wait. Don't wait. That is what I'm trying to draw your attention to. Don't wait, doctors, please don't wait, okay? And defer intervention until fibrinogen is reported. No. Fibrinogen will help you to manage cases of disseminated intravascular coagulation in the case of postpartum hemorrhage, but it should not delay in emergency management. So let's go to the management of postpartum bleeding. Let's try some questions there. So you have a 36-year-old woman who undergoes emergency delivery for placental abruption. She develops profuse vaginal bleeding and hypotension. The uterus is firm. Laboratory results show prolonged PT and a fibrinogen level of 1.2 grams per liter, which is low. Which of the following is the most appropriate management in this patient? A, continue uterine massage and oxytocin infusion. B, administer methyl-gonovin. C, initiate transfusion with packed red blood cells only. D, initiate massive transfusion protocol with RBCs, plasma, and platelets. And E, proceed directly to hysterectomy. What is the correct answer? Dear doctors, what is the correct answer? Assuming Dr. Bruni wakes you in the night and says, Doctor, you're preparing for the QE1. What is the correct answer? Answer this and then go back to bed. What is the correct answer? Is it A? Is it B? Is it C? Is it D? Or is it E? I'm waiting for your answers, my dear doctors. Please, I'm waiting for your answers. So some are saying B, B for boy. Some are also saying D, D for daddy. Will someone go for a different option? So it looks like D for daddy is now taking over. Initiate massive transfusion protocol with red blood cells, plasma, and platelets. And I can say for a fact that that is correct. Initiate massive transfusion protocol with red blood cells, plasma, and platelets. Okay? Now, how do you think through this case step by step? This is a case of placental abruption. The uterus is firm. The patient has prolonged PT and low fibrinogen. Come on, this is disseminated intravascular coagulation. I had one lecturer when I was doing my internship in Ghana, in Sunyane. One of my professors, he's currently deceased. May his soul rest in peace. He said DIC means death is coming. Death is coming, right? DIC. This patient has DIC. You know, it's a thrombin problem. So you need to correct the coagulopathy, and you need to correct the clotting factors. And you need to make sure that you use balanced transfusion, which is 1:1:1. Red blood cells, fresh frozen plasma, and platelets. So that's answer option, which talked about RBCs alone. It will not correct the coagulation deficit. It will deal with just one part of the equation. But you need the fresh frozen plasma and the platelets to help to correct the whole DIC issue, right? So please use the massive transfusion protocol. Now, why are the rest of the answers wrong? Why are you going to focus on massive and on uterine massage and oxytocin when you are still told that the uterus is firm and there's no atony? Not necessary. Why are you going to focus on methyl egonovin when you are told that the uterus is firm and it is not a uterine tone problem? Why are you going to give RBCs only? If you give RBCs only, it is not going to correct the coagulopathy, right? Now, why will you want to do immediate hysterectomy? This is a patient who is already bleeding profusely, and it is not as a result of a uterine problem or a laceration. It's as a result of disseminated intravascular coagulation. This is a systemic problem. Even going to try hysterectomy, you are even sending the patient to their early grave before the patient's time is up. Okay, now let's try this as well. You have a 28-year-old woman who develops heavy vaginal bleeding. Immediately after vaginal delivery, she's hypotensive and tachycardic. 2 large bore IV lines are placed. Uterine massage is performed, and oxytocin infusion is started. She receives methyl egonovin and carboprost without improvement. So in other words, like, you know, these are uterotonics which should help the uterus to contract, right? The uterus remains soft and bleeding persists. Which of the following is the most appropriate next step? So what steps have we taken in this case? You've put in the IV lines, you've done your uterine massage, you've given your oxytocin, which should help the uterus to contract, you've given your methyl egonovin, you've given your carboprost. Still, the patient is not improving. So now the point is this: patient has delivered. You've done first step, uterine massage. You've done next step. You've given your fluids, right? You are giving your your fluids. You are giving your oxytocin, which should help with the contraction. You've given your methyl egonovin. You have given your carboprost. All these are not helping. So now I'm asking you, what will you do next? What will you do next? A, delay intervention until coagulation studies return. B, administer additional doses of oxytocin. C, insert an intrauterine balloon tamponade device. D, proceed directly to hysterectomy. And E, transfer the patient for uterine artery embolization. Come on, let's go. Let's go. Tell me, what is the correct answer? What's the correct answer? What's the correct answer? What's the correct answer? So some are saying C, insert an intrauterine balloon tamponade device. Some are also saying D, which is proceed directly to hysterectomy. Yeah. Car racing. Is it C or D? Is it C or D? Doctors, is it C or D? Is it cat or daddy? Is it cat or daddy? Tell me, is it C or D? People are going for C. Others are also going for D. And what is the correct answer? Because C says insert an intrauterine balloon tamponade device. D says proceed directly to hysterectomy. Which one is easier to do? Organizing the theater, calling the anesthetist, blah blah blah, or going in to put a tamponade, intrauterine tamponade. Which one is easier to deal with? So the correct answer is insert an intrauterine balloon tamponade device. That's the correct answer. That's the correct answer. And why is it so? Why is it so? You realize that this patient has a soft uterus. So that means the patient probably has uterine atony. We have tried massage. It has failed. We have tried multiple uterotonics, not working. Now, what is the order you need to follow when it comes to uterine atony and postpartum bleeding? Number one, you need to start your massage. Number two, you need to give your oxytocin. Number three, you need to give your additional uterotonics, which you've given. If those three steps fail, next line, do your balloon tamponade. You do your balloon tamponade, that fails. You need to do your compression sutures, where it's a beautiful procedure. Beautiful procedure. You pass one stitch in front, you go to the back, you tie it up, and then you go to the other side. The obstetricians are wonderful in doing this. And then it is after all these have failed that you go to your ligation and hysterectomy. Remember, this is a board exam. This is a board exam. So doctors, please, the next logical step after you have failed uterotonics is uterine tamponade. So start with uterine massage. While you're doing that, get your oxytocin and other uterotonics. You try that, doesn't work, please go on to do your balloon tamponade. If that doesn't help, go on to do your compression sutures. Where you pass a suture on top of the uterus, you tie it up, you pass another. There's a wonderful way the obstetricians do it. And it is when all these are not conclusive that you think about taking out someone's uterus. Because doctors, hey, it's not an easy thing for somebody to lose their uterus when all they wanted to do was to come in and deliver a baby and go home with a bouncing baby or baby boy or baby girl, right? So you want to find a way to keep the patient alive, to keep the patient's uterus as much as possible before you say that, au revoir, we have to get rid of this uterus, because the more the uterus stays, the more we are getting into trouble. Doctors, how has it been so far? I have a question. How has it been so far? How has the class been so far? Just tell me. Has it been good? Has it helped you? Has it opened your eyes to certain things you need to know? Communicate with me. How has the class been so far? I've enjoyed it. I've really, really enjoyed it. The step-by-step principles we need to use to go through this. I've really enjoyed it. So, doctors, I want to draw attention to something. MedCognito, now we've gone to a new learning platform. And for me, it's very exciting. So if you go to the MedCognito website, we've changed things there a little bit. So MedCognito.com. We are going to active recall, but I'm just drawing your attention to what you can get in MedCognito now. Okay? MedCognito.com. So assuming I log in, right? Okay, so it will ask me for my details, right? But let's go to the website itself. So if you want to have access to the class we are having, so you just go to courses, you go to MCCQE1 prep, okay? You just click on courses. Sorry, you come to MCCQE1 prep, you click on that. If you want to have access to that, and then when you click on MCCQE1 prep, you just click on enroll now. You just click on enroll now. And enroll now should take you to this page. You have various options. You can do a one-time payment. What are you going to get? You're going to get a learning platform. On that learning platform, you have all your lectures, even before you come to class. Number two, when you come to your live classes, which are conducted every Thursday and every Sunday evening, you get a replay of that class in your portal. Number three, you have a question bank in there. Number four, you have some mock exams you can try on your own. Number five, you have what you call med drills and med bullets. Med drills is like, a review of all the concepts, but this time we mix the systems up. That is also there for you. And med bullets is, the way you prepare for your exam last minute. We've already done that in video format. We've covered more than 3,000 topics. And every 10 minutes, you are reviewing one. Every 10 minutes, you are reviewing 10 topics. Okay? Every 10 minutes, you are reviewing 10 topics. All this is in there for you. So that's what I want to draw attention to. And you can have access to everything for 6 months for just $2,199. Or you can decide to pay over 2 months, $1,150 for the first month and $1,150 for the next month. And then you can also decide to pay over 3 months, which is only $799 every month for 3 months, and you still get access for 6 months. And if you want to just do ongoing payments every month, no matter the amount of time you want to spend with us, you can just do $420 and you still get access to everything in the portal. So doctors, that's my little announcement. And I really, really need you to take advantage of this so you can get the best out of MedCognito. If you have any question, let us know. Now, I know a lot of people are really enjoying the class. So we're going to go to the active recall part of the class. And then we will land the plane on postpartum hemorrhage. Okay. So what laboratory tests? I didn't teach this one, but I'm testing you. And we'll use that as a point of study. What laboratory tests are included in a postpartum hemorrhage panel? Think about all the things which can go wrong in postpartum hemorrhage. So hemoglobin can drop, okay? So I need to request my hemoglobin levels, right? Okay, so doctors, tell me, active recall, what are the laboratory tests to include in a postpartum hemorrhage panel? Tell me, what are they? Just type your answers. Think about all the things that can go wrong. And that should direct your investigations. That should direct your investigations. What are all the things that can go wrong in a case of postpartum hemorrhage? Okay, so Dr. Joanna De Cruz says hemoglobin, PT. All right, okay. Any other? Hemoglobin APTT. Okay, there's more. There's more. So Daddy, you need to get your... Daddy, where's my baby alive? You're looking for your baby? Your baby. I'm teaching postpartum hemorrhage. Your baby has been delivered. Go and check your room, okay? So, doctors, my daughter just came in. Please, I don't have it here. Your baby has been delivered. Go and look for your baby. She's looking for her baby. Okay, so do your complete blood count. Check your PT and PTT. Check fibrinogen levels. Why? Because of the risk of DIC. Do your complete metabolic profile, which contains your liver function test, your renal panel, right? And then get your ionized calcium levels as well. Don't forget to get your blood gases. And then get your blood group, type, and cross-match. Okay? Yeah, her baby is called Baby Alive. And she was looking for the baby. So I think the baby is in another room. I said we are dealing with the mother. The mother has delivered. The mother is now in postpartum bleeding. So we need to deal with that. She's looking for Baby Alive. Okay, so complete blood count, your PT, your PTT, fibrinogen levels, complete metabolic profile, ionized calcium, blood gases, blood group, type, and screen. These are the labs you want to request for in a case of postpartum hemorrhage. Okay, let's go to the next question. Why does hemoglobin initially appear normal in acute postpartum bleeding? Why does hemoglobin initially appear normal in acute postpartum hemorrhage? I think this is very simple. We discussed it during the class, and it is because laboratory values at times can lag behind the acute blood loss. Okay, laboratory values lag behind the acute blood loss. Okay, next question. What must be monitored continuously during resuscitation of a patient with postpartum hemorrhage? What must be monitored continuously during resuscitation of a patient with postpartum hemorrhage? You know, we are just dealing with basic stuff. You know, MCQ1 is at the level of a medical student. It's not any over the top thing like syndromes and no. It's regular medical practice stuff. Regular medical practice stuff. And that is why I see at times some specialists, because of, you know, the level of practice they have, right? They think too high. No, bring it down. Think when you were in medical school, what were the things you needed to learn? Yeah. So what are the things you are going to monitor continuously during resuscitation of a patient with postpartum hemorrhage? You want to monitor the simple vitals: blood pressure, heart rate, oxygen saturation, the temperature of the patient, even the urine output, because you want to make sure that the kidneys are not shutting down. Right. Okay, good. What is the most commonly used ratio in massive transfusion? We talked about this. What is the most commonly used ratio in massive blood transfusion in postpartum hemorrhage? What is it? In fact, in massive blood transfusion, in any case, what is it? Massive blood transfusion. What's the most commonly used ratio in massive blood transfusion? Beautiful. It's 1:1:1. RBC to FFP to platelets. Okay. Next question. What metabolic complications must be monitored during massive transfusion? So you are transfusing a patient. Okay. You're doing massive transfusion protocol. Massive transfusion. What metabolic complications must be monitored? I intentionally brought these questions in the active recall part so that, you know, we can learn more concepts beyond what we did in the regular class. What metabolic complications must be monitored during massive transfusion? So remember, hypocalcemia. Let me say this: hypocalcemia. So calcium is going down. So if you are doing massive transfusion, these are the things. Don't confuse hypocalcemia and hyperkalemia. You're expecting calcium to be going down, so you want to be monitoring that. And hyperkalemia. So potassium, when you are doing massive transfusion, there's a risk of hyperkalemia, there's a risk of hypocalcemia, and there's a risk of hypomagnesemia. So which two electrolytes have the risk of going down? It's calcium and magnesium. Which one electrolyte has the risk of going up? It's potassium, hyperkalemia. Let me say it again. During massive transfusion protocol, during massive transfusion, a patient with postpartum hemorrhage, which electrolytes are likely to go down? Calcium, magnesium. Which electrolytes are likely to go up? Potassium. So if I was an examiner, I'll put hypercalcemia, hyperkalemia, hypomagnesemia A. Then I'll say hypercalcemia, hypokalemia, hypermagnesemia B. Oh my goodness. I'll just be playing with your brain. So, but if you get this right, calcium will go low, magnesium will go low, potassium will go high. What's the first physical intervention for uterine atony? What's the first physical intervention for uterine atony? What's the first physical intervention for uterine atony? Doctors, what's the correct answer? Tell me. What's the first physical intervention for uterine atony? And the correct answer is bimanual uterine massage. Give the uterus some massage. Massage the uterus. Massage the uterus. Massage the uterus. Okay. Next one. What is the next step if uterotonics fail in a case of postpartum hemorrhage? If you give your uterotonics and they fail, what is the next best step? What's the next best step after you give your uterotonics and they fail? Right? Before you give your uterotonics, don't forget that you have already started your massage, right? You've given your massage, you're doing your massage. Hey, it's not working. Oh, let's add oxytocin. Oh, no. Let's add other uterotonics. Still, patient is bleeding. What's your next best step? Especially if the uterus is boggy. Your next best step is to do uterine balloon tamponade. Uterine balloon tamponade. Uterine balloon tamponade. Uterine balloon tamponade. Okay. What surgical option may be used if tamponade fails? What surgical option may be used if tamponade fails? What surgical option may be used if tamponade fails? What surgical option may be used if tamponade fails? Doctors, what's the correct answer? What's the correct answer? What's the correct answer? What's the correct answer? And the correct answer is compression sutures. Before you get to hysterectomy, doctors, before you get to hysterectomy, remember there's compression sutures. You can even do, uterine artery ligation and all those things before you get to hysterectomy. Don't just jump into hysterectomy. Beautiful. So someone is even giving me the actual name. It's called the B-Lynch procedure. The B-Lynch, right? The B-Lynch procedure. Okay, now what is the definitive treatment for uncontrolled postpartum hemorrhage? Look at the way I put the question well. What is the definitive? When this is the oga kwata, everything has failed. What's your definitive management? My Nigerian brothers and sisters will say oga kwata, the oga at the top. This one is the oga at the top. Like you've done everything. It's still not budging. What will you do? Yeah, you do a hysterectomy. Beautiful, beautiful. Okay, now, doctors, what are the 4 T's of postpartum hemorrhage? 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 Please, let's go. What are the 4 T's of postpartum hemorrhage? What are the 4 T's? Yes, correct. It is tone, trauma, tissue, and thrombin. Tone, so you're talking about uterine, like the uterus is not contracting. Trauma is maybe cervical instrumentation, which causes cervical laceration or uterine rupture. Tissue is retained products of consumption, and thrombin is a patient with bleeding disorder or a patient who gets into bleeding disorder. Okay, soft and boggy uterus, heavy bleeding in a postpartum patient. What is your diagnosis? Soft and boggy uterus plus heavy bleeding in a postpartum patient. What's your diagnosis? Uterine atony. Simple. Uterine atony. Right? Postpartum hemorrhage plus a firm uterus. What are you thinking about? Postpartum hemorrhage plus a firm uterus. What differentials are you thinking? Postpartum hemorrhage plus a firm uterus. What differentials are you thinking? Remember what we learned, right? You're thinking about trauma, thrombin, or tissue. Trauma, because the uterus can be contracted, but the cervix may be lacerated. So trauma, thrombin, or tissue. Okay. Postpartum hemorrhage after prolonged labor plus a soft uterus. Postpartum hemorrhage after prolonged labor plus a soft uterus. What are you thinking about again? Again, it's the same thing we talked about. Uterine atony. Uterine atony. Okay, next one. You gave oxytocin and the patient still has a soft uterus and the patient has postpartum hemorrhage. What are you thinking about? What are you thinking about? You gave oxytocin. Beautiful, beautiful. It's still uterine atony. I'm just hitting there because uterine atony is the cause of majority of cases of postpartum hemorrhage. Okay, now you did instrumental delivery, the uterus is firm, and there's postpartum hemorrhage. You did instrumental delivery, now the uterus is firm, but there's postpartum hemorrhage. What's your answer? It's a birth canal laceration, right? Trauma. Okay, good. There's heavy bleeding days to weeks after delivery. 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 What are you thinking about? I'm going to think about secondary postpartum hemorrhage. And it can be as a result of tissue, right? Tissue, some retained products of conception there, okay? Postpartum bleeding plus a firm uterus plus heavy menstrual history. So the patient, even before they became pregnant, had, concerns with heavy menstrual bleeding. Now they got pregnant. They delivered a bouncing baby boy, normal weight, no laceration, but the patient is still bleeding. The patient is still bleeding. The patient is still bleeding. What's the diagnosis? So the patient may have a bleeding disorder or a coagulation concern, right? Good. So doctors, that is it. This is my phone number, +1 306 891 5649. +1 306 891 5649. I will respond myself. And I know that the class just ended. I'm going to get a bunch of messages and calls. Remember, you can join MedCognito's platform with only $420 every month, or you can do a one-time payment. I know that is what a lot of candidates love. That's what a lot of candidates love. But I'm still going to share the screen with you. I'm going to share the link with you. You can use that to register right now. You have a class tonight. Remember, you have a class tonight. And then come Thursday as well, you have another class. And so many goodies are coming in your MedCognito portal very, very, very soon. So if you think you have a lot, just wait. More stuff is coming. So many goodies. I've dropped a link. You can click on that to register. Join us. Let's get into the game and prepare and go beat the QE1 exam. This is my phone number, +1 306 891 5649. Just give me a call right now. Right now, because this weekend is family weekend. I'll be spending some time with the family. I'll be putting the phone off. But if you want to talk to me right away, please give me a call. I prefer a WhatsApp call so that even if you're outside Canada, we can still have a conversation. And don't forget that there will be others on the phone. So let's make our conversations snappy. Let's get everything going. I'm here to serve you with our team. So why not jump on the MedCognito train and let's get this ball rolling. I've been blessed today. Thank you for spending your day with me. I'll see you in another class somewhere on YouTube. Spread the good news of MedCognito to as many friends as possible. All the best, doctors. Bye-bye.